Shock is a life-threatening medical condition. In this segment, we'll review the various types of shock that can affect children and model how to effectively treat the condition. Shock is a condition of circulatory failure that results in inadequate delivery of oxygen and other nutrients to the tissues. Shock can be present with a low, normal, or even high cardiac output. The cardiac output is inadequate to meet tissue oxygen needs. Shock is progressive, so the child in shock requires urgent care to avoid cardiac arrest. Because shock is progressive, the child in shock will deteriorate, and may deteriorate rapidly. As a result, it's critical to identify the signs of shock and provide treatment as soon as possible. There are 4 types of shock: hypovolemic, distributive, cardiogenic, and obstructive. Let's explore each of these.
Hypovolemic shock is the most common type of shock in children worldwide and is the result of volume loss due to vomiting, diarrhea, bleeding, or inadequate fluid intake. Signs of hypovolemic shock include tachycardia and poor perfusion. The level of consciousness may be normal at first, but it will decrease as shock progresses. During the initial stages of hypovolemic shock, the blood pressure may actually be high due to the release of catecholamines. As shock progresses, the blood pressure will fall. If hypotension is present, immediate treatment is needed to prevent cardiac arrest.
Well, distributive shock is present when there is inadequate blood flow to some tissue beds, but too much blood flow to others. It is typically associated with vasodilation and some capillary leak and decreased heart function. The clinical presentation of distributive shock is more variable than that of hypovolemic shock. Like children with hypovolemic shock, most children with distributive shock have tachycardia. Some also have a typical sign of poor perfusion, which is cool skin with delayed capillary refill. Unlike patients in hypovolemic shock, however, some patients in distributive shock may have warm, flush skin with brisk capillary refill. The most common form of distributive shock is septic shock that results from a systemic infection. Severe infections can release toxins that cause the small blood vessels to dilate and to leak fluid into the tissues. Septic shock is generally preceded by signs and symptoms of infection, such as fever. With some types of infections, the child may develop a petechial or purpuric rash. Progression of septic shock may occur over hours. Another common form of distributive shock is anaphylaxis that typically results from a severe allergic reaction. The allergen can cause the release of chemicals within the body that make the small blood vessels dilate and leak fluid into tissues, like septic shock. However, anaphylactic shock can develop extremely fast, often within just minutes.
Cardiogenic shock results from inadequate tissue perfusion caused by poor myocardial function. Common causes include congenital heart disease, myocarditis, or acquired dysfunctions such as cardiomyopathy. Other less common causes include arrhythmias, sepsis, drug toxicity, or direct myocardial injury. With cardiogenic shock, children often have marked tachycardia, accompanied by very high systemic vascular resistance and severe vasoconstriction and decreased cardiac output. Pulmonary congestion may develop, causing respiratory distress. Intravascular volume may be normal or high unless the child has had poor oral intake.
In obstructive shock, cardiac output is impaired by physical obstruction to blood flow into or out of the heart. Obstructions may be caused by air, fluid, or blood clots, such as in tension pneumothorax or cardiac tamponade. Obstructive shock may also be caused by massive pulmonary embolus, or result from congenital heart defects that cause severe obstruction to pulmonary, aortic, or systemic blood flow. Many of these lesions are called ductal-dependent lesions that depend on a functional ductus arteriosus for pulmonary or systemic blood flow. Once the ductus starts to close after birth, these infants can deteriorate rapidly. And because cardiac output is impaired in both hypovolemic and obstructive shock, it can be difficult to distinguish the two.
After the child has been categorized as having one of the 4 kinds of shock, It is essential to define the severity as being either compensated or hypotensive. Shock with adequate blood pressure is termed compensated shock.
Patients in compensated shock may have a normal or even high systolic blood pressure due to the fight or flight response. This compensatory mechanism produces systemic vasoconstriction that initially maintains blood pressure. Shock with a low blood pressure is called hypotensive shock. Low blood pressure is defined as a blood pressure less than the 5th percentile for age. Hypotension occurs when the compensatory mechanisms have failed. Hypotensive shock in children is an ominous finding and requires immediate intervention.
Regardless of the type of shock, it's critical that you know about the various devices and procedures used in the management of this serious condition. There are several important considerations in the monitoring and the management of shock. For monitoring patients, place them on a cardiac monitor, continuously measure pulse oximetry, and perform frequent blood pressure measurements. In managing shock, rapid vascular access is needed for fluid therapy and drug administration.
For children in compensated shock, peripheral venous access is preferred if it can be obtained rapidly. But for children in hypotensive shock, immediate vascular access is critical, so a team member should be prepared to establish intraosseous or IO access. IV or IO fluid bolus therapy is indicated for treatment of shock. The primary goal of fluid resuscitation in shock is to restore adequate blood flow to the tissues. The rate and the volume of the fluid bolus are determined by the child's condition. The rate of fluid delivery will be affected by the size and the length of the IV catheter. Give fluid boluses rapidly for hypovolemic, distributive, and obstructive shock.
In the case of cardiogenic shock, the fluid bolus should be smaller and given more slowly. Rapid delivery of fluids in the setting of poor myocardial function can cause pulmonary edema and further impair cardiac output. This can further compromise oxygenation, ventilation, and cardiac output. Give a bolus of 5 to 10 milliliters per kilogram of body weight by using isotonic crystalloid. Give the bolus over 10 to 20 minutes. Carefully monitor hemodynamic and respiratory parameters during fluid infusion and repeat subsequent infusions as needed.
For a child in shock, the preferred initial fluid for resuscitation is an isotonic crystalloid solution, such as normal saline or lactated ringers. Dextrose-containing fluids shouldn't be given for shock resuscitation. If you do not know the child's weight, use a length-based resuscitation tape to quickly estimate the weight and the fluid bolus volume. Measure from the top of the head to the heel. The child's heel will fall on boxes that list not only the typical fluid bolus for shock, but emergency doses of medication and sizes of emergency equipment that should be used for that child. The typical bolus volume for shock is 20 milliliters per kilogram of isotonic crystalloid, administered over 5 to 20 minutes. The equipment used for routine pediatric intravenous fluid administration may not deliver fluid boluses as rapidly as needed for most children in shock. One way to deliver fluids rapidly is to use a commercially available rapid infusion device. Another option is to set up a rapid push-pull system. Anytime fluid is being administered rapidly, providers must be aware of the risk of air embolism. Air embolism can occur when air gets infused from the fluid bag after all the fluid has been given.
Here's how to set up the push-pull system using commonly available supplies. Follow these steps to give a fluid bolus with a syringe and a 3-way stopcock. Verify that the vascular access is patent. Connect a bag of isotonic crystalloid with a 3-way stopcock and extension tubing to the IV or IO access. Attach a large syringe to the stopcock. To draw up the IV fluid into the syringe, turn the stopcock off to the child and open between the syringe and the bag of IV fluid. Draw fluid from the bag into the syringe. Turn the stopcock off to the bag and open between the syringe and the child. To rapidly infuse the fluid bolus from the syringe, push the fluid from the syringe into the child. Repeat these steps until after the total desired volume of fluid bolus is delivered. After the bolus is delivered, turn the stopcock off to the syringe and open between the child and the IV bag. Reset the continuous IV infusion rate as appropriate. Carefully assess the patient after each bolus. Auscultate the lungs and feel for hepatomegaly. If crackles, respiratory distress, or an enlarged liver develop, the child is likely to need additional therapy, such as an administration of an inotropic drug, for example, epinephrine, or an inodilator, such as milrinone. Some patients in shock may need additional respiratory support, such as continuous positive airway pressure, or CPAP, or intubation and mechanical ventilation after fluid resuscitation. For children with fever but no signs of shock, routine IV fluid boluses are not recommended. Benefit has not been shown in these instances, and there may be harm where access to critical care resources is limited.
For patients with suspected septic shock, antibiotics should be administered within the first hour of care. In addition, administration of vasoactive drugs will be needed and should be administered if the child does not respond to initial fluid boluses. For patients with cardiogenic shock, small, more frequent fluid boluses may be needed, but must be done cautiously. Most patients will need inotropic support with medications such as milrinone or epinephrine. For obstructive shock, treatment must be directed at the underlying problem. For example, with tension pneumothorax, needle decompression is required. For cardiac tamponade, pericardiocentesis is indicated. For ductal-dependent congenital heart disease causing obstructive shock, prostaglandin infusion may be life-saving. While searching for the cause of the obstructive shock, administration of small fluid boluses and vasoactive drugs such as epinephrine may help support cardiac output. You should also seek expert consultation.
Knowing how to recognize the signs of shock and treat the condition effectively are essential skills for you to learn. Your ability to manage this condition can save lives.